Dibakar Biswas from Kolkata, DM Endocrinology. And today I will present or describe one case unit and some practical aspects of management of type 2 diabetes. So now I start with my case that a 50-year-old male patient, type 2 diabetes for 4 years. He is obese, he is hypertensive also, and patient is also dyslipidemic, and this is suggestive of obstructive sleep apnea. And on physical examination, BMI was 32, blood pressure is normal, and heart rate around 60, and baseline laboratory parameters, hemoglobin A1c was 8.3, calculated EGFR was 70, with LDL of 69, HDL of 35, triglyceride of 250, and raised AST and ALT. And the patient was on metformin 1000 milligram twice daily with ACE inhibitors and beta blockers, statin, and aspirin. Regarding patient profile, the history of diabetes is short, so he is a young patient and has no major comorbidities like cardiovascular or renal diseases, with no major complications that would reduce his lifespan. He is also at low risk for hyperglycemia. He would benefit from a more stringent course. However, he is also obese, he is hypertensive, he is lipidemic, and also suffers from obstructive sleep apnea. So we should consider all these things together before prescribing a treatment. So what does ADA recommends that in this group of patients, we should target hemoglobin A1c less than 7%, and this should be a reasonable goal for most non-pregnant adults. And in addition to efficacy, following considerations predominate in determining the pharmacotherapy for him and should avoid, or the chance of hypertension should be less. And we should also consider the weight loss or at least minimize weight gain, and also related to heart failure, atherosclerotic cardiovascular disease, kidney disease, and also we should consider the cost also. So that male patient is willing to start another medication, but is concerned because he sometimes forgets to take his pills, and he fears that additional pills will only make this worse. So there is a problem of compliance. He does not want to have injectable therapy. Fixed dose combinations may improve patient adherence by once daily dosing. Less complex treatment regimens are preferable so that it also improves the side effect profile and adherence. And people with type 2 diabetes commonly live with multiple comorbidities, among which hypertension and cardiovascular disease are the most common. Monotherapy cannot address these multiple aspects and often leads to failure to maintain glycemic control. So, current diabetes guidelines encourages early adoption of oral combination therapy. So, it is very important. While should simultaneously emphasizing the importance of individualized treatment. Again, the ADA recommendation in appropriate high-risk patients established type 2 diabetes, the decision should be individualized, and we should prescribe GLP-1 receptor agonist or SGLT2 inhibitors to reduce the cardiovascular related or kidney related endpoints. So, EMPA and LINA, this is one of the beautiful fixed dose combination is available as first class treatment in SGL2 and DPP4 combination group of drugs. And you all know that this SGL2 inhibitor is a class of novel oral glucose lowering agents that mediates glucose lowering action and by increasing the urinary glucose excretion, and that is independent of beta cell function, and it acts throughout the spectrum of type 2 diabetes, and its salutary effects on its ability to act independent of insulin excretion. So it can be given throughout the stages, and there are so many evidences in favor of empagliflozin regarding cardiovascular outcome, regarding kidney outcome, and you all know that the 3P MACE outcome is very significant. And again, if you consider the CP safety of the linagliptin, the DPP4 inhibitor, and that is also documented, and decrements by EMPA and LINA combination demonstrated a significant reduction of A1C. at the tune of 1.8%. So that is very important. As the patient's target is 7 and already the patient is more than 8. So if we do this combination, it actually reduces the complications. So we should start we should start this thing on the background of metformin, and the benefits on glycemic control were maintained at week 52 on metformin patients. A higher percentage of patients achieved A1c less than 7% as and are reported for contained combinations. The combination offers a suitable component in strategy and so that the compliance will be better, there is risk of hypoglycemia is less, and at least it reduces the weight gain, and to some extent it reduces the body weight also, and it improves the lipid profile. So a reduction in the incidence of genital infections associated with SGLT2 inhibition has been reported, and the DP4 inhibitors is added, whereas because of better glucose control, although other possible mechanisms remains to be investigated. So, in summary, EMPA and LINA combination provides robust hemoglobin A1c reduction and 2 to 4 times higher odds of patient reaching the goal in A1c compared to individual agents with low hypoglycemia risk. Thank you.